Well, schizophrenia, I think in a man's basic language is what people think is Wendawazimu. But they assume that mental illness is generally Wendawazimu, not knowing that somebody who has psychosis, it's only an aspect, a 1% aspect of mental illness. So schizophrenia, if I would describe it, it's when a person loses touch with the reality. That is the actual thing that happens. And when they lose touch with the reality, they start presenting symptoms that are bizarre. Majority of them are the type that will hear voices that other people are not hearing. And when you see them on our streets, they tend to talk to themselves. They tend to be addressing things that are not there. They will also, a few of them may see things that are not there. But the most significant thing that you notice with schizophrenic is the disorganization of their behavior. In the sense that showering, the normal habits that we have as a human being, remembering to be clean, changing your clothes, that will be affected. They tend to repeat the same clothes, they tend to not be aware of how they look or how they are too dirty, and they remain in that nature. On top of that, there are people who have issues with socialization. A parent will tell you that my child will sit by themselves, they will be inside the room, or they will stay somewhere without movement. They don't have the proper interactional skills like everyone of us. They cannot sustain a conversation. And that means that naturally you have to be the person to reach out to them than the other way that we are used to. The conversations tends to be one word answers, what we call monosyllabic. You ask the question, they answer, and then they pause and wait for the next one. It is not an engaging conversation. Beyond the bizarreness, they tend to be the kind of people who will be having some delusions. They will tell you that they're being people are attacking them. They're being monitored, especially where there is a room or a place with CCTV. They'll feel that there's communication coming through, or they'll feel that things are being stolen from them, especially the thoughts or words inserted. And some of them, behavior-wise, when they're trying to prevent themselves from that, they'll close their ears or they tend to wear a muffin so that that kind of control is not there. So you find that the interaction, the delusions, the hallucinations, and their presentation will change. And this also affects their functionality because schizophrenia is a chronic condition that is also progressive. So they'll tend to not, they'll be very good before the illness sets in, which a majority of the time we find that for the boys is between the age of 15 to 25, but for girls is a bit much later, maybe from 19 to 29. And this is a child, somebody would say, was originally very intelligent, high achievers, but all of a sudden they cannot be able to keep up with school, performance is failing, and they're not able to function at all. Parents would say that this is a child who's been lazy. All of a sudden they could be able to do something, but now you have to keep motivating them. Oga, toka hapa, keti hapa. In fact, they'll be in their room, there's vyombo kwa meza, but they don't have that initiation or motivation to do anything. And in what, in our terms, we call a motivation kind of syndrome, but apparently we describe it as a new sudden laziness.
Mood disorders, as the name suggests, are disorders that primarily affect the mood. And by definition, mood is the emotional feeling tone of a person. And that emotional feeling tone can become disordered in various ways. Depression has very specific diagnostic criteria. Like I pointed out earlier, you cannot take an X-ray of somebody's brain and say they have depression. But if they tell you that certain symptoms are aggregated together, number one, a depressed mood for a period of at least 2 weeks or longer, depressed mood, loss of interest, feeling very bored and disinterested in most things, combined with the biological symptoms of sleep disturbance, appetite disturbance, energy disturbance, and libido, loss of libido, as biological symptoms. And then there are psychological symptoms like losing pleasure, not being able to enjoy things you've enjoyed in the past, feeling hopeless and worthless and helpless and suicidal. And then there are cognitive symptoms like difficulty making decisions, being indecisive, feeling inappropriate guilt, which is more of a psychological symptom, but inappropriate guilt, small things that happened in the past, we now seem to assume a certain level of significance from the individual. And you don't need all those symptoms to make a diagnosis. In fact, the catalog says if the person has had either a depressed mood or loss of interest, then they need 4 of the other symptoms. But if they have both depressed mood and loss of interest, then they just need 3 of the other symptoms. Because of the impulsivity of mania or hypomania, the person very easily loses the control and they find themselves back there. And the same with depression, that the person may self-medicate because they're in a depressed state. However, if you do not manage the bipolar itself, then you are guaranteed that your patient will never come out of that substance. Yeah. You must manage the bipolar.
I think we must accept that the workplaces are progressively becoming very stressful to employees. The workplaces are not very sensitive to employees. They are more interested in what they get from the employees. And so that we are finding that there will be a number of problems, psychiatric or mental health problems, which will increase, in particular, anxiety states, depression, and alcoholism. In any workplace, there will be people will fall ill, and the workplaces must plan for people falling ill while they work for them, because it is a natural process. And you will find that a number of organizations who, particularly who are have a human face, they will have made some provisions for the treatment of the people who fall ill, and particularly the people who become mentally ill. The treatment of mental disorders take a long time. But let me reassure you that with good care and with good follow-up, we know people who are mentally ill who have been so productive. The problem is that no provisions are made for them, and so they become less productive. And of course, that has some financial implications to the organization.
There's a big link between mental health and substance disorder, because most of our clients will always have an underlying issue. But because they do not know where to go for help, they will always try to cope. And remember, some mental illnesses, or maybe a majority, does affect your judgment and your decision making. And most of the time, you will choose what is not good for you. So while we're having that area, or the cognitive aspect of that compromise, and you're dealing with the low mood, and all what you know is, if I take cannabis, or if I take weed, it will uplift me, or if I drink alcohol, I will run away from the issues. You find that most of them will use alcohol as a negative coping mechanism. And you see, the problem with using substances is that it will give you a brief relief or a short-term relief that further plunge you into the depths of the illness, especially if it's depression, or even contribute to a development of another comorbidity. For example, if you're using cannabis, then you end up becoming psychotic, or even getting a mood disorder. And you find that patients are stuck in that loop until they find help.